What's the plan now?
344.
30. Lower laterals.
Yes, lower all laterals.
All laterals.
Already one teeth fell off. This is quite weak. So better, there was a deep bite.
Yes.
So slowly the patient is having the upper population also. See, if we want to remove only this tooth, can you place 2 implants?
No.
Either the implant will be too close or the adjacent tooth will get no disturbed. If you place only 1 implant and give tooth, it is more than 2 teeth gap.
Yes.
2.5 teeth. So lot of cantilever will be there. So better to give a uniform aesthetic result. Only 2 implants. Yes. So mild lip incompetence is there. That is because of upper anteriors. This is the occlusal view. We'll see the CBCT. Okay. We'll see the panoramic view. And we will plan without CBCT. Okay. 2 laterals. 2 lateral extraction. Just you have to axial implant. Follow the root just straight away. You don't have to tilt mesially or just straight implant. Maybe here this may become close to the. Oh, sorry, this lateral also we are going to remove, right? Okay, this lateral we are going to remove. This one, this one. There is some lesion in this 3-2 already. Do we need to open the flap?
No.
No need. There is nothing. There is not necessary. What implant you will select?
Gears.
Compressive or basal? Both implant is possible. After extraction, check the labial plate.
Yes.
If it is intact, you can place a compressive implant. If there is a labial bone defect, better place a basal implant. So that can be decided only during extraction. After extraction, check the labial plate. If it is good, you can place a compressive implant. What will be the length? What length you will select?
Then
don't see the X-ray. You cannot measure by seeing the X-ray because we don't know where is the curvature, where is the resistance. So what is the correct answer? During drilling, I will feel the resistance, then I will respect the resistance, I will measure the length, then I will select. So what will be the diameter? Definitely 4 is not needed, above 4 because the socket is very small. Use a 3.75. Okay. So the diameter is below 4. The length is determined by resistance. Whether compressive or basal is determined by the after extraction check the labial plate. So if there is severe perio pocket infection, better to select a basal smooth surface. So this won't give you idea about length. By seeing this, you cannot determine length. Only 2 options: either take CBCT or during surgery you can. Even if you take CBCT during surgery, you have to respect the resistance and determine the length. So for 4-2, we'll be planning now. Yeah. See the shape. It is a kind of CS. Exactly. This is a C shape. C shape are more prone for perforations because we'll be drilling, and we won't respect it. It will perforate. Okay. So through the apex you drill. Wherever you are feeling the resistance, here there is fully cancerous. But here it is good. We are not going to do any alveoloplasty. So we'll be using this. So if you place a compressive, you will get stability from the crestal part, from the middle part, and little bit from the here. But there is no bone here. If you use a basal
is not good.
Yes, crustally it won't get any support. Only from here, buccal and lingual, it will get support. If you insert too much, the implant will become loose.
Yes.
Okay. If you insert till here, the implant will become loss its stability. So if you are using this, try to stop. No, try to stop only till here. So that. Okay. So both compressive and basal, they are good here. They will work. Okay. So we'll see the length. So we'll be using 3.75 into 16. Probably 16. If we are using basal, we have to include the soft tissue length also. 20 or 70. Okay. So if you are using basal, try to stop before. If you are using compression, you can go longer length. So it's in the 3D, 360 degree view. So in this view, we can see how much close to the adjacent tooth. In IUP itself, we can see. We can see that a small lesion here in this tooth. So we place an additional implant here. 3, 2. Here, once you remove this socket, remove this tooth, the adjacent tooth socket is there. This periapical infection is there. Okay, that you have to consider. If you place a compressive, that infection is close. The defect is close. So better we can place a basal. This is the buccal lingual section. So if you use a 3.6, it will get buccal lingual cortical support. Okay. Or you can use a compressive also, provided you do nice curettage and nice irrigation. You will check there's a small lesion is there, right? Maybe come on or vital. So in the mind, go through the sequence. LA, extraction, curate, check the labial plate also, because during extraction sometimes the bone may come out, the plan may change at the time. Curate, irrigate, then pilot drilling, select whether compressive or basal. If it is compressive, pilot drilling is enough, no need for pilot drilling. Select the length and place it. Now you got a fair idea about anatomy, right? Anteriorly, the shape will be different. Pear shape, straight, C shape. In the premolar, it is like a tubular, right? The premolar. In the molar, you will see the myloid ridge. See how much prominent it is. This is the basic anatomy. Some minor variations will happen. You can see the metal foramen is very big here on this patient. So you know the metal foramen is actually very, very wide, right? It is actually very wide. Once we saw a patient where there is no metal foramen completely on both sides. I was wondering. Then I checked the literature. There was 2 case reports till now. Completely no metal foramen outside. I don't know. How much will And one more thing is, the important thing is the mandibular midline. Okay. So this is the midline. Actually the mandible didn't come free. You can see the lingual foramen here. The lingual vessel is coming inside. Okay. So during drilling, if you perforate outside and if you perforate this lingual vessel which is entering here, the bleeding here, no? You will see the hematoma here. The tongue will bulge. So bleeding from this lingual vessel on the lingual side due to perforation and injuring this is a very dangerous complication.
Sir, this also acts as a bleeding angina. Patient has breathing problems.
Yes, breathing problems.
Medical emergency.
Medical emergency, yes. So that is why respecting the resistance is important.
Even in crystal, we have to be very careful.
Okay.
most careful area is lower anteriors.
Yes.
Life-threatening complication.
So the same kind of foramen, it is in the midline. There is a foramen, and there are accessory foramens also present on each side. Okay. So the important vessels are coming here, and they'll be coming out. There'll be two foramens above the tubercle, below the tubercle.
Even bleeding cannot be controlled very easily.
Yes. We have encountered one such time.
Even I did extraction 1 to 2 months back.
Okay.
So, lingually, yes. So, there was very heavy bleeding, which I controlled almost 15 to 20 minutes later. Like,
from the LA injection site?
Yes, injection site, and I break the bone.
Okay.
And while I was elevating, I did something unusual. So, lingual side, there was very heavy ooze out.
See, it is open. It is open. You are doing cautery and all. When it is closed, it elevates the tongue and all.
சிவியரா லாசரேட் பண்ணினா வராது. அத நம்ம பாக்கும்போது 7 days கழிச்சு தான் பாக்குறோம். பட் உள்ள நல்லா லாசரேட் பண்ணி everything like open compound work.
Maybe I thought when you are opening,
it's a very thin bone, sir, and very hard bone. Maxillary lower anteriors. So drilling is difficult. Burrs usually slip here and there.
Till now, there are 5 to 6 cases of death due to implantology. The reason is lingual perforation.
Some patients, I heard cases that some patient has been hospitalized. Tracheostomy has done.
So immediately we cannot compress.
Yes, you can. Once it happened, we did compress.
But if it is profuse, you cannot do anything.
See, one technique is to put gauze over the tongue and pull it.
Okay.
That will put compression on the vessel also.
Okay.
That is one technique, and to give compression. But the thing is that the difficult area to give compression.